Okay. So today's class hand surgery part 2, page number 1971, infections. Infections, first infection is superficial paronychial infections. So paronychia is the most common infection of the hand. So it usually results from the trauma to the epineuchial or paronychial region. Okay. So they can confuse you like this with the statement like trauma to the epineuchial region causes paronychial infection. So it might confuse you. So trauma to epineuchial infection also causes paronychia. Okay, that is the most common infection of the hand.
Yogesh, audio கேக்கல ஸ்டார்ட் பண்ணிட்டியா? ஹலோ
கேக்கலையா ஆடியோ?
இப்ப கேக்குதுடா.
Okay. So infection, superficial paronychial infection. Paronychia is the most common infection of the hand. They usually result from the trauma of the epineuchial or paronychial region. Come to the next page. So you can see the spaces in the diagram. They can ask you. So A is your paronychium. Okay. B is your pulp space. So phelon infection, phelon is the infection of the pulp space. C is your volar subcutaneous infection. And D is your subcutaneous infection on the dorsum of the digit. And E is your web space infections. Okay. So E might confuse you. E is web space infection. Okay. And C is volar subcutaneous infection. So most common causative organism of paronychia is Staphylococcus aureus. So the surgical approach depends upon the extent of the infection. Incisions may not be necessary. Okay, this is important point. We know paronychia we drain with an incision. So incision may not be necessary. A freer elevator is used to lift approximately 20% of the nail adjacent to the infected perinechium, extending proximally to the edge of the nail. This portion of the nail is transected and gauze packing is inserted beneath the nail fold. A single incision to drain the affected paronychium also allows elevation of the epineuchial fold when both the epineuchium and paronychium are involved. So 25% of the freeze, you can elevate using an elevator, freeze elevator, and you can drain the tissue and just excising the affected nail part alone. Okay, no need to remove the total nail. And if both epineuchium and paronychium are involved, in that case, a single incision has to be placed. So, am I audible?
Okay, Yogesh, audible.
Okay. Infections of the intermediate depth spaces. So, in this, with the infection of the digital pulp space, one must not wait for the fluctuance before making the decision for the surgery. Okay, so digital pulp space infection, don't wait for the abscess to fluctuate. Similarly, can you tell me a few examples where you don't wait for an abscess to fluctuate, where early incision and drainage is preferred?
Breast.
Yes, one is breast, another one is parotid. Okay. Third one, I'm not sure. It's perianal abscess. I'm not sure. But parotid and breast, you should not wait for the abscess to fluctuate. Similarly, in digital pulp space, don't wait for fluctuation to appear. So a single volar or unilateral longitudinal incision may be used. Okay. Then, so pulp space infection at the base of the finger can travel through the lumbrical canal into the palm to create a deep palmar space infection. Then, so here incision is placed transversely across the web space and a longitudinal counter incision may be placed dorsally between the bases of the proximal phalanx. A generous communication is established between these two incisions. You can see the incisions in 70.39. This is more important. Okay, so incision for web space abscess between the little and the ring finger, where you have to place in the palmar aspect and then the dorsal aspect, and you have to make both of these things to communicate. Similarly, in the previous page, note for the incision of the paronychia and phelon. Remember, A is for paronychia, B is for phelon. Next, deep space infection, palmar space infection. So between that, it happens between the metacarpals and the palmar aponeurosis. First point, okay. Between the metacarpal and the palmar aponeurosis, a transverse septum to the metacarpal of the middle finger divides the deep space into an ulnar, mid-palmar, and radial thenar space. The transverse head of the adductor pollicis partitions the thenar space from the retroadductor space. So this is an MCQ, which divides the thenar space from the retroadductor space? So answer is transverse head of the adductor pollicis. Okay, adductor pollicis. So on the volar side, an incision is made adjacent and parallel to the thenar crease. Great care is taken to avoid injury to the palmar cutaneous branch of the median nerve. I told already its location is 5 to 6 centimeter proximal to the flexor retinaculum or the wrist joint. Then so we have to avoid injury to the palmar cutaneous branch of the median nerve in the proximal part of the incision and the motor branch of the median nerve in a deeper plane. A second slightly curved longitudinal incision is made on the dorsum of the first web space. Next MCQ point is so in mid-palmar space infection. Next, coming to the mid-palmar space. Okay, in mid-palmar space, we have to place a longitudinal curvilinear incision. Okay, so you can see in the diagram 70.40 they have given. Okay, so 1 minute. So this thing. So B is for incision for the thenar space infection. I already told, and C is for the incision of the mid-palmar space abscess. This might be asked, which is for thenar space and which is for mid-palmar space. Mid-palmar space, curvilinear incision. So thenar space infection, just a perpendicular incision, but in the proximal aspect, you just take care that you don't cross the wrist joint and go proximally and injure the median nerve or the palmar cutaneous branch of the median nerve. And a few more MCQ points, the spaces in this diagram. Okay, so note it down, which is thenar space and which is retroadductor space. The muscle in between it is transverse head of the adductor pollicis. Okay, and this one is, which is medially, is mid-palmar space. So these are the MCQs. So the above diagram shows that is easy only, how the spaces communicate with each other. So flexor tendon space sheath space is there, then ulnar bursa is there, radial bursa is there. So ulnar and ulnar and radial bursa communicate with each other. So flexor tendon sheath it might communicate to the deep palmar space. So next, infection of the Parona space. So what is Parona space? Parona space is the potential space deep to the flexor tendon in the distal forearm and superficial to the pronator quadratus muscle. So between the pronator quadratus muscle and the flexor tendon. Okay, this space is called as the Parona space. So it is usually from the adjacent side spread. Okay, from the other sides it will spread to this Parona space. So in this case, active digital flexion will be painful, as well as passive finger extension also. So a surgical incision must be placed to leave the median nerve adequately covered with the soft tissue. They haven't given the extent or shape or just nothing. Okay. Next is pyogenic flexor tenosynovitis. So Canavel's 4 cardinal signs. This is an MCQ. So what are the 4 cardinal signs of Canavel? The finger is held flexed because this position allows the synovial sheath its maximum volume and eases pain. Okay, then symmetrical fusiform swelling of the entire finger is present with edema of the back of the hand. This they might call as the frog's hand also. Then the slightest attempt at passive extension of the affected digit produces exquisite pain, and the site of maximum tenderness is at the proximal cul-de-sac of the index, middle and ring finger synovial sheaths in the distal palm, or in case of the infection of the sheath of the thumb and the little finger, more proximally in the palm. That's what we saw in the diagram as well. Next, so bursal space infection, it can communicate. So it will create a horseshoe abscess. Next, so it is treated with the IV antibiotics. Okay, when to abort this? If the patient is seen with maybe aborted with the parenteral antibiotics extremity, and if the patient is seen within the first 24 hours of the infection. If this course is unsuccessful, or if the patient is seen more than 48 hours, surgical drainage is undertaken. Okay, so first 24 hours if the patient present, you can treat with IV antibiotic. If it is more than that, especially more than 48 hours, surgical drainage should be done and 2 separate incisions should be given. Okay, two incision. First incision is the mid-axial incision made on the finger, usually on the ulnar side of the digit. Okay, on the radial side of the thumb or the little finger. This is the very, very important statement. Okay, you will give a mid-axial incision on the fingers. Okay, all the fingers you give it on ulnar aspect of the digit, whereas for thumb and little finger you should give it on the radial aspect of the digits. Okay, so the digital artery and the nerve remain in the volar flap with the dissection proceeding directly to the tendon sheath. So that synovium between the A3 and A4 pili is incised and cloudy fluid is encountered. So second incision is made in the palm over the tendon to drain the cul-de-sac. So then a catheter should be inserted beneath the A1 pulley. So and it is flushed with sterile saline every 2 hours after the surgery. So this is the surgical procedure, key points in this flexor tenosynovitis. Okay, two incisions you have to give, separate incision, mid-axial incision on digits on the ulnar side, for thumb and little finger on the radial side. Then you incise the second incision is given over the tendon to drain the cul-de-sac, okay, little proximal. Then you insert a catheter beneath the A1 pulley and flush it with the sterile saline every 2 hours after the surgery. So next is chronic and atypical infections. So chronic paronychia is generally the result of the Candida albicans in more than 95% and is not bactericidal. This is the first MCQ. Okay. Then chronic infection is not bacterial. Then chronic tenosynovitis. So treatment is surgical excision of the involved synovium and prolonged treatment with the appropriate antimicrobial agents. So synovectomy should be done. Next, herpetic whitlow. So it is caused by type 1 or type 2 herpes simplex virus and it can be confused with the paronychia. So key symptom is the pain is out of proportion to the physical finding. Treatment is generally non-operative because the infection is usually self-limited. Then animal and human bites. So most striking difference between the microbial flora of human and animal bite wound is the highest number of bacterial isolates per wound in the human bites. So always humans are more dangerous, okay, than animals. The difference being mostly caused by the presence of an anaerobic bacteria. Then, so in human bites, the incidence of the Echinella corrodens, okay, that is around 7 to 29%. They have not given most common, but I guess it's the predominant organism, most commonly encountered organism, Echinella corrodens. Then MCQ wise, animal bites, you will get the Pastorella multocida. Okay, that is the difference. You remember for human bites, it's Echinella corrodens, and for animal bites, it's Pastorella multocida. So it is isolated from only 26% of the dog bite wound. Okay, so in dog bite, there will be usually a polymicrobial infection. Multocida is seen only in 26%. So most animal bites cause mixed infection of aerobic and anaerobic bacteria. Then you have this fight bite wounds. Okay, so fight bite wounds of the metacarpal phalangeal joint need to be explored surgically, debrided and thoroughly lavaged. Okay, so you remember that statement alone. Fight bite syndrome of the metacarpophalangeal joint, you have to explore surgically, debride and lavage it. So human bite wounds are not closed primarily and are treated with appropriate antibiotics. Next, coming to the compartment syndrome, high pressure injection injury and extravasation injury. I guess this is given better in daily.
The human bites face it's close primary, la?
Yes.
Okay, thank you.
Then high pressure injection injury. So this high pressure injection injury, the type of material injection is injected is the most important prognostic factor. Okay, that is one statement. So especially if it is associated in the thumb and the little finger, it will extend into the radial and the ulnar bursa. So apart from that, not much important points. So last 3 lines, radiographs may help determine the extent and dispersion of the injected material, either in the form of subcutaneous emphysema or with lead-based paints, it will appear as a radio-opaque shadows. So the entire digit must be the right side above. The entire digit must be surgically decompressed and all the foreign material, necrotic tissue will be debrided. So the wounds are closed loosely over a Penrose drain or in a delayed manner. So we have to give antibiotics. That's it. Then extravasation injury. So if extravasation is suspected, infusion must be stopped immediately. Cold pack should be, especially with chemotherapy drugs and all. Okay. So extravasation is suspected, infusion should be stopped. Cold pack should be applied for 15 minutes, 4 times a day, and it is elevated during the next 48 hours. The treatment is generally effective for this treatment is generally effective for most extravasation. However, if blistering, ulceration, or pain, gangrene, necrosis happens, that is treated similar to an ulcer. We have to debride and later we have to close it with a grafting. Next, compartment syndrome. First thing is Volkmann's ischemic contracture. It's an important thing. So it is the sequel of untreated compartment syndrome. It results in the muscle that is fibrosed, contracted, and functionless, and nerves that are insensible. So various injuries are known to cause the compartment syndrome. So first one is here, reasons are, so decreased compartment volume. For example, externally applied tight dressings or cast lying on a limb in a comatose state. Then increased compartment content. For example, bleeding or trauma with fracture or finger injuries, increased capillary permeability after and reperfusion injuries, electric burn injuries. So in all these things, there will be increased compartmental content. Okay, so decreased compartment content volume is like external pressures comes under decreased compartment volume. So other injuries are snake bite injuries, high pressure injection injuries, and all. So muscle ischemia that lasts for more than 4 hours leads to muscle death and may also cause the significant myoglobinuria. After 8 hours of total ischemia, irreversible nerve changes are complete. The hallmark of the muscle and the nerve ischemia is pain. Okay, so more than 4 hours, muscle death will be start. Then after 8 hours, total ischemia and nerve damage will be complete. So hallmark of muscle and nerve ischemia is pain. So pain is accentuated by passive muscle stretching. This is the most reliable clinic test for diagnosis of the compartment syndrome. So pain on passive stretching is the diagnostic test. So then tenderness and all will become. So arterial nerve injury should be distinguished in the DD of compartment syndrome. So all three of these injury produce paresthesia or paralysis. This is important. Compartment syndrome or an arterial injury, nerve injury, all causes paresthesia and paralysis. Okay, so like some few points I've written in the side. So most common
to disappear the fine touch and the point compartment syndrome.
I'm not sure. Compartment syndrome, fine touch will go first or what? I'm not sure. I'll check and let you know.
Okay.
So most common muscles involved are the deep muscles. Okay, in the forearm, that is the flexor digitorum profundus and flexor pollicis longus. Okay, this was taken in some class I saw somewhere. Okay, most common muscles involved are deep ones, especially FDP and FPL. So intrinsic muscles, we have to do a Bunnell's test. Okay, so what is Bunnell's test for testing the intrinsic muscles of the hand in compartment syndrome is if you extend the metacarpophalangeal joint, it will limit the proximal interphalangeal joint flexion. Okay, so MCP extension limits the PIP flexion. That is called Bunnell's test. It's used for testing the intrinsic muscles of the hand.
Bunnell's test, can you repeat?
Bunnell's test என்னன்னா நீ மெட்டாகார்போஃபெலிஞ்சியல் ஜாயிண்ட்டை வந்து எக்ஸ்டெண்ட் பண்ணிட்டேன்னு வச்சுக்கோ, பிஐபி ஜாயிண்ட் ஃபிளெக்ஷன் பண்ண முடியாது. ஓகே, அதான் Bunnell's டெஸ்ட். அது அப்படி போயிடுச்சுன்னா அப்ப வந்து உனக்கு இன்ட்ரின்சிக் ஹேண்ட் மசில்ஸ்லாம் கம்பார்ட்மெண்ட் சிண்ட்ரோம்ல இருக்குன்னு அர்த்தம்.
ஓகே.
So அடுத்து கீழே Volkmann's ischemic contracture, I've written some points about it. So minor form of Volkmann's ischemic contracture, you have to treat it with the passive stretching and splintage. Okay, if it is severe form, then you have to go for Z-plasty, tendon slide or tendon transfer. Okay, all these things. So the last point in these things, Pain with passive stretch is present in compartment syndrome on arterial occlusion, but not in neuropraxia. So this might be a true or false statement. Okay. Pain on passive stretch is seen not only in compartment syndrome, but also in arterial occlusion also, but it is not seen in the neuropraxia. Okay. And pulses are intact in the compartment syndrome and neuropraxia, but not with the arterial occlusion. So these are the differentiating points between these three. So, okay. So in compartment syndrome, here they have given pulses are intact in the compartment syndrome, but it's not in all cases. In later stages, there will be pulselessness. Okay. So release of the forearm compartment syndrome always requires the carpal tunnel release. So the incision must avoid the palmar cutaneous branch of the median nerve and prevent flexion contraction across the wrist grease. It also provides an opportunity to release the Guyan's canal. So incision, the palmar incision should be placed between the thenar and the hypothenar muscles, and then the incision should curve transversely across the flexion crease of the wrist at the ulnar border. Next to this side, the dorsal and so-called mobile VAD compartments of the forearm. Mobile VAD, what is mobile VAD? I already told about the three groups. Okay, 6 compartments. That is six after 6 compartment is for the tendons when it passes under the retinaculum. Okay, so these 3 groups are of the extensors located dorsally. Okay, what are the 3 groups? One is mobile VAD. Mobile VAD will comprise of the extensor carpi radialis longus, extensor carpi radialis brevis, and the brachioradialis. Okay, so these mobile VAD compartment syndrome is treated by releasing through a straight incision. Okay, most wounds can be partially closed at 5 days. If the skin cannot be closed secondarily within the 10 days, a split thickness skin graft can be applied. So next is decurvent stenosynovitis. Decurvent is a stenosynovitis of the first dorsal compartment of the wrist. Okay, that is the first MCQ. Which compartment of the wrist is involved? First dorsal compartment. So, and it's the most common cause of pain and disability, and it's a common cause of. So there will be a history of pain localized to the radial side of the wrist. So MCQ is positive Finkelstein's test. Okay. So what is Finkelstein's test? The patient clasps the thumb and brisk ulnar deviation, it will elicit a pain in the first dorsal compartment. That is called Finkelstein's test. This positive in decurvents. So first primary treatment will be non-operative treatment. If the non-operative measures fail, surgical decompression of the first dorsal compartment of the wrist is performed. Care must be taken to protect the, so first dorsal compartment, so I already told which nerve passes through the anatomical snuff box, that is the radial sensory nerve branches. Okay, so this traverses just under the skin in this area, and trauma or transection may lead to a painful disabling neuroma. So you can see the diagram, okay, which is the first dorsal compartment, this is the second dorsal compartment, okay, which is the site of the decurvents disease. Next is intersection syndrome. So it is closely related to it. Okay, they might give this diagram. So intersection syndrome is not well understood, but is characterized by the pain and crepitus at the point. Decurvents will also have crepitus. Okay, so intersection syndrome, they have a pain and crepitus at the point at which the abductor pollicis longus and the extensor pollicis brevis tendon cross over the tendons of the second dorsal compartment, that is ECRL and ECRB. When APL and EBP cross over the ECRL and ECRB, that is where intersection syndrome happens. So treatment is non-operative initially by splinting, local corticosteroid injection, and anti-inflammatory medications. So refractive cases will require surgical release at the second dorsal compartment and excision of the involved tenosynovial membrane. So next is trigger thumb and finger. So trigger finger is a constricting tenosynovitis of the flexor tendon. Okay, so it is generally encountered at the proximal edge of the A1 pulley. So the patient can flex the digit, but an apparent nodule catches at the proximal edge of the A1 pulley, locking the PIP joint, okay, or the interphalangeal joint of the thumb in this flexed posture. Okay, so if you want extra edge, you write it down. That nodule, the nodule which catches is called as the nota nodule, N-O-T-T-A, notas nodule. Okay. So patient can flex, okay, but an apparent nodule will be catching at the A1 pulley. So it will lock the finger and locks the PIP joint or the interphalangeal joint in case of the thumb in the flexed position. So attempts at extending the digit can cause it to snap back suddenly like a trigger. Okay. So in its most severe form, the condition is so tight that the patient cannot flex the digit, or it becomes fixed in a flexed position and can no longer be fully extended. Okay, either he cannot flex in severe cases, or even if he flexes, it cannot be extended. So congenital form of the trigger thumb or fingers in presence in infants, but most cases resolve by the time the child reaches 1 year of age. This is important line. Okay, so trigger thumb can occur in children also. That is, congenital form is also there, but it resolves spontaneously within 1 year of age. If not, then an operation is indicated. So non-operative treatment in adults include the local injection of the corticosteroids. If this regimen fails, the A1 pulley is longitudinally divided by the surgery. So what are the other sites of tenos innovatis is flexor carpi radialis and flexor carpi ulnaris tendon. Okay. Next, nerve compression syndrome. So the most common site of the nerve compression syndrome from proximal to distal along the length of the extremity are at the nerve root secondary to the cervical disc. That is the first point. Or cervical degenerative arthritis. Then you can have the nerve compression in thoracic outlet compression at the level of the clavicle. Then ulnar nerve entrapment at the elbow. That is called as cubital tunnel syndrome. Or you can have a radial tunnel syndrome. Radial tunnel syndrome means entrapment of the PIN nerve in the proximal forearm. That is also called as the posterior interosseous syndrome. Then entrapment of the median nerve and its branches in the proximal forearm. That is called as the pronator syndrome or anterior interosseous nerve syndrome. So two MCQs. One is anterior interosseous nerve syndrome. Which nerve is compressed? That is median nerve. Posterior interosseous nerve syndrome is posterior interosseous nerve compression. Okay. Then AIN syndrome is also called as the pronator syndrome. Then what is carpal tunnel syndrome? We know median nerve. Then Guyon's canal, we know near the hamate, hook of the hamate. We have that is ulnar nerve. So what are the causes of this thing? One is trauma causing the bone compression. Then synovial thickening of the bursa in rheumatoid arthritis. Then tumors such as giant cell tumor in the Guyon's canal or lipoma. Then developmental causes such as anomalous muscles present in the carpal tunnel. Then metabolic causes such as myxedema, pregnancy. All these things are causes of compression. So carpal tunnel syndrome is the most common peripheral nerve entrapment syndrome, followed by the ulnar nerve entrapment at the elbow. So second most common will be your cubital tunnel syndrome, not Guyon's canal syndrome. Okay. Ulnar nerve can get compressed in Guyon's canal also, in cubital tunnel also. Cubital tunnel is more common. So diabetes is a risk factor for carpal tunnel syndrome. So, but studies suggest that patients with diabetes do similarly well as the patients who are normoglycemic do after the carpal tunnel release. So prognosis is similar in diabetics and non-diabetics, although diabetes mellitus is a risk factor. So we will see the individual conditions. First is the carpal tunnel syndrome. So carpal tunnel floor is formed by the carpal bones and roofed by the flexor retinaculum. That is also called as the transverse carpal ligament. So normal pressure is 20 to 30. So progressive conduction block, okay, with subsequent sensory and motor dysfunction. So the earliest symptom in carpal tunnel syndrome is pain and paresthesia, which is more obvious at night after prolonged activity and with positional postural changes at the wrist. So there will be clumsiness of the hand. So physical examination consists of compressing the so there are three signs in this carpal tunnel syndrome. One is Durkan sign, second one is Tinel sign, third one is the Fallon's test. So what is Durkan sign? Compressing the carpal canal. Okay, that is Durkan sign. So next, percussing the median nerve is the Tinel. So Tinels means you will percuss, you know. Okay, Durkan means just compressing. Then Fallon's is hyperflexing the wrist to produce the paresthesia. And all these tests you will feel the ultimate symptom is paresthesia only. but the maneuvers are different. So hyperflexing the wrist, like keeping a namaste, that is called as the Fallon's test. So thenar weakness or muscle wetting is a late finding. Okay, thenar muscle weakness is a late finding. So treatment is wrist splint, especially at the night, occasionally local corticosteroid injection and modification in the work pattern. If symptom persist or if the initial presentation shows severe carpal tunnel, then surgical decompression is required. This is performed by longitudinally dividing the flexor retinaculum by open or endoscopic means. So there are two approaches for dividing the flexor retinaculum, okay, through an endoscopy. So they have given one name. So single portal approach is called as the AGE approach. So two portal approach is called as the chow. Okay. Then you remember chow mean will eat with two chopsticks. So two portal approach is chow. So this efficacy is similar to that of the open approach. Next is pronator syndrome. Pronator syndrome, in the proximal forearm, the medial nerve may be compressed at the fibrous arch between the two heads of the FDS, two heads of the pronator teres, then lacertus fibrosis, that is bicipital aponeurosis at the elbow, and the ligament of the Struther. So all these are MCQ. What are the compression sites in the pronator syndrome? They will ask. Between the FDS heads, between the pronator teres heads, then at the bicipital aponeurosis of the elbow, also called as the lacertus fibrosis, and fourth one is the ligament of Struther. So nocturnal symptoms are uncommon. That is the important point to distinguish from the carpal tunnel. Nocturnal symptoms are uncommon. The palm may also feel the numb because the palmar cutaneous branch is involved, but it is specifically spared in the carpal tunnel syndrome. So the second differentiating point is palmar cutaneous branch is involved in the pronator syndrome, whereas it is spared in the carpal tunnel syndrome. Then surgical decompression often involves release of all the four potential sites of the compression. Next is anterior interosseous nerve syndrome. So anterior interosseous nerve, branch of the median nerve, may occasionally be compressed in isolation. This does not produce any sensory symptoms, but specifically targets the three muscles innervated by the AIN. One is FPL, another one is FDP to the index and the middle finger, and the third muscle is the pronator quadratus. Okay, so important point in AIN syndrome is there is no sensory, only muscle involvement. Three muscle, FPL, FDP to the middle and the index finger, and your pronator quadratus. Already we saw this pronator quadratus as a boundary for the Parona space. Okay, so in this additional point, you note it down. The OK sign will be positive. Okay, OK sign means we'll tell super, no? Super, like that the hanger will become. Okay. No, the hand won't become. It's a test. If you won't be able to perform that super sign, that is called as the OK sign. Then ulnar nerve compression, it can be compressed in the Guyan canal or in the cubital tunnel. Guyan's canal is at the wrist, cubital tunnel at the elbow, and the distal upper arm. So Guyan's canal compression, causes of Guyan's canal compression is, one is ganglion or giant cell tumor, then ulnar artery thrombosis, ulnar artery aneurysm. Okay. So hypothenar hammer syndrome is also similar only. We saw already yesterday. Then treatment is surgical for Guyan's canal compression, dividing the palmaris brevis muscle and the palmar carpal ligament, as well as removing any offending mass in this region. So next is cubital tunnel syndrome. So as the ulnar nerve passes into the forearm, it curves tightly around the grooved posterior and inferior surface of the medial epicondyle of the humerus. So it is bridged by the aponeurosis between the two heads of the FCU. Okay. So if the flexor carpi ulnaris aponeurosis becomes thickened, it causes compression of the ulnar and causes the cubital tunnel syndrome. So that is this ligament is also called as the Osborne ligament. Okay. So another site of compression is the arcade of Struther. Okay. So two things we have seen. One is arcade of Struther, another one is ligament of Struther. Okay. Already I told you in pronator syndrome, I told you the site, I told it is ligament of Struther. So they will ask which nerve is compressed in ligament of Struther. So median nerve is compressed in the ligament of Struther. Whereas in arcade of Struther, ulnar nerve is compressed. Okay. Most important point. Take home message, I will say. Okay. Arcade of Struther and ligament of Struther. Ligament of Struther is medial nerve. Arcade of Struther is ulnar nerve. Sorry. Arcade of Struther is ulnar nerve. Ligament of Struther is median nerve. So another site is the medial intermuscular septum in the upper arm. So the most distal fibroosseous tunnel is more accurately termed the cubital tunnel. So what are the, in cubital tunnel syndrome itself, there are various places. One is the Osborn ligament. Osborn ligament is the thickening of the FCU. Another one is the arcade of Struther. Okay. Third is the medial intermuscular septum. And fourth is the most distal fibroosseous tunnel, that is called as a true cubital tunnel. So compression on the ulnar nerve can occur at any of these sites. So treatment is generally non-operative, like splinting and all. Failure of non-operative measures and significant changes in electrodiagnostic studies are indications for the surgical decompression. So next is radial nerve compression. So radial nerve may be compressed proximally in the triangular space in the axilla, specifically involving the axillary branch, then spiral groove posterior to the humerus in the arm, and lateral intermuscular septum proximal to the elbow. More distally in the forearm, posterior interosseous nerve, the principal motor division of the radial nerve can be compressed in the so called as the radial tunnel. So radial tunnel syndrome is PIN nerve. So another one site of compression is the ligament of Froese. Okay, so this ligament of Froese, so this radial tunnel, no, in this radial tunnel, the starting point is your ligament of Froese. Okay, so that because of this, the PIN nerve will get compressed. So 3 points to remember. One is 3 ligaments I am going to tell you. I have written above. One is the ligament of Struthe. So ligament of Struthe, it is pronator syndrome. That is the median nerve. Okay. Then ligament of Froese. Ligament of Froese is your radial nerve. Okay. Ligament of Osborn is your ulnar nerve. 3 ligament, 3 different nerves. Osborn, ulnar. Froese, radial. Struther's, it is median. So you remember MS, okay? Median nerve is for Struther's ligament. Whereas arcade of Struther is for ulnar nerve. So these 4 points are important. Okay, with this itself, we can rule out and write MCQ. So next is thoracic outlet compression. So it is the space bounded by the first rib medially, the scalenus anterior muscle and the clavicle anteriorly, and the scalenus medius muscle posteriorly. Here they will confuse mainly with this scalenus medius muscle. Scalenus medius, but it is not the medial boundary. Medial boundary is first rib. Scalenus medius will be posterior. Okay. Scalenus anterior and clavicle will be anterior. So test we have seen in this CTVS section itself. AdSense test. Okay. Then costoclavicular compression test. All these things. So thoracic outlet obstruction may occur in association with other peripheral sites of nerve compression. That is called as the double crush syndrome. So treatment is primarily non-operative, involving the posture improving exercises and avoiding of the aggravating activities. So what is double crush syndrome? Thoracic outlet compression along with peripheral site of nerve compression. So below I have written 2 comparative points regarding the septum. One is medial intermuscular septum, another one is lateral intermuscular septum. So in medial intermuscular septum, ulnar nerve will be compressed. In lateral intermuscular septum, radial nerve will be compressed. So I guess in today's class, this page is very, very important. Okay, I recommend you to read one more time. Then tumors. Tumors, ganglion and mucus represent 60 to 70% of the hand tumors. So the most common tumor in hand is ganglion and the mucus cyst. So this tabular column, it summarizes all the conditions, but it's difficult to go through this tabular column. So let's go into the theory and read and then come back to this tabular column. So benign tumors are most common, 95%. SCC is the most common malignant neoplasm. So primary bone tumor of the hand are benign. So the most common benign tumor, benign bone tumor of the hand are enchondroma and osteochondroma. Okay. So next, soft tissue tumors. First one is ganglion cyst. Ganglion cyst, 60 location is 60% occur on the dorsal aspect of the wrist. Okay, then arising in the region of the scapholunate ligament. So this has been asked once. Okay, most common site of the ganglionic cyst, they gave in the option scapholunate ligament. Okay, so it is an important MCQ. Then other aspect are volar wrist, then scaphoid articulation at flexor tendon sheath area of the A1 pulley, then dorsum of the DAP joint, okay, called a mucous cyst, where they often associate with osteoarthritis of the DAP joint. So all these places are the locations of this ganglion cyst are given in the diagram. Okay, most common is the dorsal wrist ganglion. Other sites are volar wrist ganglion, then flexor sheath ganglion, then mucous cyst at the DAP, which is associated with the arthritis. So it can also occur in the nail bed, forming, causing a grooved nail. Okay. Then next para, ganglions are most common in women in the third decade of their life. Okay, most common age group is third decade, most common in women. The dorsal wrist ganglion can sometimes be painful as a result on a pressure of the PIN. So this can be asked. Dorsal wrist ganglion causes compression of which nerve? Posterior interosseous nerve. A very small impalpable dorsal wrist ganglion can become quite painful. That is called as the occult ganglion. Okay, occult ganglion is seen in the dorsal wrist. So for occult ganglion diagnosis, you have to do an MRI. So treatment is aspiration with a large bore needle. If it fails, then you have to go for excision. So primary treatment is not excision, it is aspiration. So volar, last line, volar wrist ganglion may often be closely related to the radial artery. Okay, dorsal, it is nerve, posterior interosseous nerve. Volar wrist ganglion, it is related to the radial artery. So aspiration of the volar wrist ganglion is seldom advised. I told you aspiration is the first treatment option, but in volar wrist ganglion alone, because of the potential risk to the radial nerve injury, excision should be done. Okay. So at the level of the DAP joint, optimal treatment includes not only meticulous excision of the ganglion, but also removal of the associated osteophytes. So in DAP joint also, you do a excision and along with the osteophytes. Next is giant cell tumor. So giant cell tumor is also called as pigmented villonodular synovitis. This is the second most common hand tumor. So it is a yellow-brown multilobular tumor. It is frequently asymptomatic and is often larger than suspected clinically. So complete excision is the treatment. So if you don't remove all the lobes of the giant cell tumor, so in giant cell tumor, what appearance you will get? That's given in bone chapter in Bailey. That will be soap bubble appearance, I guess. So yeah, all the lobules should be removed. If you don't remove, recurrence rate will be 10%. So synovectomy of the joint of origin may be necessary. So next is epidermal inclusion cyst. So it occurs after trauma as keratin producing epidermal cells become lodged in the subcutaneous tissue. It's more common in the men, especially the manual laborers, and most frequently involve the palm of the hand and the fingertips. So it may also occur in the previous surgical scar. Treatment is surgical excision. Next is lipoma. Lipoma in the hand, they usually, this is important, most common site of lipoma in hand. Okay, usually it is nape of the neck, lipoma. You have to see in the question, they mentioned in hand, it is thenar eminence. Next, pyogenic granuloma, highly vascular granulation tissue at the previous site of trivial trauma. It will be so painful. Okay, excision should be done. It is easily confused with the amelanotic malignant melanomas. Okay, so one DD for amelanotic malignant melanoma is pyogenic granuloma. Then verruca vulgaris. Verruca vulgaris caused by HPV type 1. So on comparative point, Herpetic whitlow is herpes simplex virus 1 and 2, whereas Verica vulgaris is human papilloma virus type 1. So they usually occur as a hyperkeratotic filiform lesion on the digits or about the nail bed. So most effective topical treatment agents are salicylates, liquid nitrogen, cryotherapy, and curettage. So recalcitrant lesions responds to oral cimetidine given for 6 to 8 weeks and to imiquimod. So all other things it's common. You just remember this cimetidine. Oral cimetidine for 6 to 8 weeks is effective in Verica vulgaris caused by HPV. So like SEC, their incidence is increased in the immunocompromised patients and those in the transplant recipients. So recurrence is relatively common. Next is seborrheic keratosis. So seborrheic keratosis are most common on the dorsum of the hand in the older adults. So they are confused with the pigmented BCC. So two DDs have shown. One is amelanotic melanoma, DD is pyogenic granuloma. Another one is pigmented BCC is confused with seborrheic keratosis. So treatment is a shave excision. Next is keratoacanthoma. So it grows rapidly during approximately 3 weeks into a nodule with a central umbilicated keratotin plug. This is the key word. Okay, image-based question. It is there in Bailey. Central umbilicated keratotic plug. The resulting scar is even worse after this spontaneous resolution than if the lesion had been excised initially. So excision is better because it will produce less scarring. Next is dermatofibroma. These also will have a central umbilication. Then vascular malformation and hemangioma. So they are rarely visible at birth and usually noticed weeks to months later. Okay. So rapid proliferation occurs in the first year of the life. Then hemangiomas occur 10 times more common than the vascular malformations. So which is more common, hemangioma or vascular malformations? Hemangioma are more common. Okay, and approximately 70% of hemangioma involved by the age of 7 years, leaving a fibrofatty scar with redundant skin. So on occasion, oral and injectable steroids may be necessary to control the rapid proliferation. Okay, then other treatment options are propranolol. So propranolol, which reduces basic fibroblastic growth factor and vascular endothelial growth factor expression, is sometimes added in conjunction with steroids for problematic hemangioma. So steroids can be given and beta blocker propranolol can be given. So by contrast, vascular malformation show normal endothelial growth characteristics. This point is important. In hemangioma, there will be proliferation of the endothelial cells with increased mitotic activity. Okay. Whereas in vascular malformation, they have normal endothelial growth characteristics and normal mast cell counts. They are often noted at birth and growth is usually commensurate with the child for low flow lesions. They do not undergo spontaneous involution. So vascular malformation, they are classified into low flow, high flow, capillary, venous, lymphatic, then arterial and AV fistula are high flow lesions. So all this no need. So combined surgical excision and radiological embolization are the most effective. So treatment, they will ask for AV malformation. So best treatment is excision along with embolization. So next, basal cell carcinoma. So generally it occurs in the dorsum of the hand. Squamous cell carcinoma also occurs in the dorsum of the hand. So 16% of actinic keratosis may progress to SEC. So arsenical keratosis may develop secondary to arsenic exposure, but have a predilection for palm. So this is important. So arsenic induced SEC have a predilection for palm. So our SCC less than 2.5 centimeter, wide excision with 6 millimeter margin is recommended. So routine prophylactic lymphadenectomy is not needed. It is advised for recurrent tumors. Okay. Then malignant melanoma.
Yogesh, the margins for SCC on the tumor chapter it's different, la?
Yes. Don't follow this one.
Okay. அது எவ்வளவுன்னு தெரியுமா? அது less than.
Actually, gross margin will be 1 centimeter. Pathological margin is 5 millimeter. Here,
4
that's
mm,
what they have given us.
4 mm margin.
4 mm, somewhere they have given 5 mm. Minimum 4 mm, I guess. Okay.
Okay.
I guess in Bailey they have given gross 1 margin. 1 centimeter and
some
vertical is
size
5
cut off
millimeter.
if it is less than 4 centimeters 4 mm margin, more than 4 centimeters 1 centimeter margin, and some size cut off.
Yeah. As far as I remember, Sabiston has given 4 millimeter, Bailey has given 5 millimeter. Gross margin is 1 centimeter. You don't follow this one. Okay. This different. It's not given in depth. Then malignant melanoma also you don't follow in this thing. Okay. Only one point you follow in this: invasive melanoma of the nail bed. They ask, it is amputation at the next most proximal. That too invasive. Not all melanoma at the nail bed. So next, coming to the bone tumors. Bone tumors also, it's not given in detail. Better to read in Bailey. Osteo. So a few points I will tell. Very common points I will tell. Osteoid osteoma. Okay, this will more they occur in the hand. They causes night pain. So treatment of choice is for osteoid osteoma is NSAIDs. Okay, this is important. So they will give a history, painful lesion in the night and all so things. Okay, these tumors produce prostaglandin. So treatment of choice is NSAID. But definitive treatment is surgical. So aneurysmal bone cyst. Aneurysmal bone cyst, there's an expansile osteolytic lesion. So it is usually derived from pre-existing bone tumor, usually a giant cell tumor. Okay. So most common site is upper extremity. I guess most common site is proximal humerus for this aneurysmal bone cyst. So there will be an increased overlaying skin temperature. That is important point for aneurysmal. Local warmth will be seen. Then enchondroma. So most common bone tumor of the hand is enchondroma. Peak incidence second decade. Gender prediction is equal. Then frequently asymptomatic and incidentally noted as a lytic lesion. So treatment for enchondroma is important. It's not excision or something. It is curettage and bone grafting. Okay, this is constant. Everywhere they have given enchondroma treatment is curettage and bone grafting. So this they have given in a box in Bailey bone chapter. Multiple enchondroma is called as the Olier's disease. Olier's disease plus angioma is called as the Maffucci syndrome. All these three are pre-malignant conditions. Okay, they have a risk for malignancy. Next, coming to the congenital anomaly. Congenital vacral anomaly, you know, nothing in the MCQ in that page. Next page you go. 1 minute. So only few points, facts like that you remember. So radial ray. So some congenital anomaly of the extremity, especially radial ray, may be associated with bone marrow failure. That is Fanconi syndrome. So Fanconi syndrome is associated with radial ray. Okay, then all these things are story only, not much important MCQ. No need, no MCQ in this thing. So another statement is this third paragraph. Duplicated thumb correction is carried out before the 1 year of age. That is one MCQ. So in early polysacchariation of the index finger, the first dorsal interosseous muscle hypertrophies to form the thenar eminence, and the first metacarpal, formerly known as the proximal phalanx of the index finger, broadens. If the centralization of the wrist for radial dysplasia, formerly known as the radial club hand, has been undertaken early, the head of the ulna broadens to resemble the distal end of the radius. So this one are not that much important. Okay. So in between what I have written here is the distal lymphedema can act as a compression band. Okay. So these may require urgent release. Then unusual entity is the aplasia cutis. That is also treated in the neonatal period. This is just vaguely they have given about the congenital anomalies. The MCQ area is this area. Okay. So what are the congenital hand anomalies? First one is syndactyly. Syndactyly means it results from the failure of the programmed cell death apoptosis between the individual fingers. Okay. So that is fused fingers are syndactyly. Okay. Polydactyly is extranumerary digits. Okay. Then third one is your thumb hyperplasia. Fourth one is your clinodactyly. Clinodactyly means curving of the digits. Okay. In the radial or ulnar direction. Then fourth one is here camptodactyly. Camptodactyly is congenital flexion deformity of the digits. And sixth one is here constriction band syndrome. So syndactyly is fusion, polydactyly is supernumerary digits. Then thumb hypoplasia, self-understood. Then clinodactyly is curving, either in curving of the digits, either in the radial or the ulnar direction. Then camptodactyly is congenital flexion, then constriction band syndrome. We'll see in detail. First, syndactyly results from the failure of the apoptosis between the individual finger rays. So it results in the fusion. So it can involve part or the all of the length of the digits. So if it is involved along the entire length of finger, it is complete, or else it is incomplete. So, and it can be limited to skin and soft tissue only. That is called simple. If it involves the bone also, it is called as complex. Then one important syndrome to remember in syndactyly is Uppert syndrome. Uppert syndrome means craniofacial anomalies and is a severe form of bilateral symmetrical complex syndactyly. So what they will ask is, they can ask which syndrome is associated with syndactyly. Answer is apex. What is seen in apex? Bilateral symmetrical complex. Okay, complex means bone, it will involve the bones also, and it's symmetrical also. So that's it in syndactyly. Second one is polydactyly. Polydactyly is present of extranumerary digits on the hand. So it is classified as preaxial or postaxial. Preaxial means radial polydactyly. That is in the near the thumb, there will be extra digit. So it is not as common as the postaxial. So more common is the ulnar polydactyly or post-axial polydactyly, okay, which is most frequent congenital hand anomaly in the African Americans. So it can be simple like a skin tag, or it can be complex like it will share blood vessels, nerves, and bone also. So thumb polydactyly are not merely a duplication, but a splitting of the single digit with a variable degree of development in each of the separate parts. Okay, this is one important statement. So polydactyly of thumb is not a mere duplication. It is a splitting of the digit. So there is a classification for thumb polydactyly. That name itself is an MCQ. Wassel's classification, WASSEL. Okay, so which is based on specific duplication progressing from the distal to proximal, in which the odd numbers are at the distal proximal phalanx and the metacarpal, and even numbers are at the interphalangeal metacarpal middle phalanx, and another one is carpometacarpal joint. So all these things you don't need to remember. Wassel's classification you should know. There are 7 types that you should know, which is the most common type in thumb polydactyly is type 4. Then type 7 is refers to associated triphalangia with the duplication. So you come to the next page, there is a diagram. Okay, if at all they ask the diagram, they will ask this only. Type 4 is the most common one. So that is given in the diagram A. Okay, then B is your type 6 polydactyly. Okay, these 2 things you remember. And in theory, they have given one more point, that is type 7. Type 7 is associated with triphalangia with the duplication. So next one is your thumb hypoplasia. So thumb hypoplasia is a classification that is called as a Bloth classification, BLAUTH. Okay, it has 5 types. For type 1 means minor hypoplasia, type 5 means total thumb absence. Okay, that's it. Then clinodactyly. Clinodactyly is curving of the digits in the radial or the ulnar direction. So it is common, particularly involving this. So it is more common in the little finger. Okay, so little finger in generally in many patients it will be curved. So which is pathology? A curvature of more than 10 degrees is considered abnormal. Up to 10 degree, it is not clinodactyly. So the distal phalanx is usually affected. So among the little finger also, the distal phalanx curvature is more common. So and a delta phalanx may be associated. A delta phalanx occurs when the epiphysis forms a C-shaped around the metaphyseal core in the middle phalanx. So operative intervention is seldom required for the clinodactyly. Delta phalanx means C-shaped defect. Okay, C-shaped curvature around the metaphyseal core. So next, 5th congenital hand deformity is here camptodactyly. Camptodactyly is congenital flexion deformity of the fingers. So it usually affects the little finger PIP joint. This is important. Clinodactyly also little finger but distal phalanx. Camptodactyly little finger but PIP joint. Okay. So treatment is non-operative for camptodactyly and may involve the serial splinting. So last one is the constriction band syndrome. I guess it was asked in this Ames. I didn't write. Hello? Pardon? So constriction band syndrome, Prem told me that this was asked in this year's Ames. Okay. So it is secondary due to intrauterine amniotic band. So this intrauterine amniotic band, it will act like a tourniquet and it will threaten the viability of the digits and even limbs. So it will result in a congenital amputation. So congenital amputation is called as the constriction band syndrome. So infants may suffer from a similar problem from the external ligature effect of a cotton strands coming off the protective booties or even from human hair. So hair, so from the underwear, this cotton threads also cause this constriction band syndrome. But these causes are acquired. Congenital cause means it is because of the amniotic band. Okay. So if it is because of hair, it is called as the hair thread tourniquet syndrome. So I can see in the diagram how amniotic band has constricted the fingers and it has resulted in the amputation. This diagram is very, very important. So next is osteoarthritis and rheumatoid arthritis. So arthritis may be primary or secondary. Secondary means post-traumatic. Then come to the next page. So 1 second. Charge.
Because hair எப்படி சொல்றாங்க? Hair thread tourniquet syndrome.
அதான அது கன்ஸ்ட்ரிக்ஷன் பேண்ட்ல ரெண்டு டைப் இருக்கு. ஒன்னு கன்ஜெனிட்டல், ஒன்னு அக்வைர்டு. கன்ஜெனிட்டல்னா ஆம்னியாட்டிக் பேண்டால வர்றது. ஓகேவா? அக்வைர்ட்னா ஏதாவது முடிக்கிட்டு எதனால மாட்டிக்கிட்டு குழந்தைகளுக்கு ஆம்புடேட் ஆயிடுச்சுன்னா அது ஹேர் த்ரெட் டார்னிக்வெட் சிண்ட்ரோம் சொல்றான்.
முடி மாட்டி ஆம்புடேட் ஆகுது. அப்போ
பிறந்த குழந்தை உன்னோட முடி எடுத்து டைட்டா சுத்திட்டா, அம்மாவோட முடி எடுத்து அது விரல.
ஓ அப்படி. ஓகே ஓகே.
டார்னிக்வெட் ஆகி மை கேங்க்ரீன் ஆயிரும்ல.
ஓகே ஓகே.
அதுதான் ஹேர் த்ரெட் டார்னிக்வெட் சிண்ட்ரோம். ஓகே. ஸோ அவ்வளோதான். ஆஸ்டியோஆர்த்ரைட்டிஸ் சொல்லிட்டேன். பிரைமரி செகண்டரி ரெண்டு இருக்கு. செகண்டரி வந்து போஸ்ட் ட்ராமாட்டிக். ஓகே. தென் ஜஸ்ட் காமன் பாயிண்ட்ஸ் யூ வில் நோ. So fibrillation will happen. The cartilage weakens and develops the crack. So these cracks are called as the fibrillation in arthritis. Then the bone will the ends become sclerotic. So these sclerotic ends are called as the eburnation. So all these things we have read in ortho, just brushing up. Okay, fibrillation, eburnation and all. So the joints usually affected in the hand, that is important. So DIP and PIP of the finger and the carpometacarpal joint at the base of the thumb. These are the commonly affected joints in the finger. So the nodes are important. So osteophytes at the DIP joint are called as the Herndon nodules. At the PIP joint it is called as the Bouchard nodules. I have remembered as BPHD. Okay, BP. Bouchard is proximal interphalangeal joint. HD, Herndon nodules, is distal interphalangeal joint. So the GIP joint is involved, the best treatment is arthrodesis. Okay, if the PIP joint is involved, then it is replacement arthroplasty or arthrodesis. Anyway, you can treat. Then thumb carpometacarpal joint is treated with arthrodesis. Okay, so everything arthrodesis. For PIP joint alone, you can do arthroplasty also. Then especially thumb metacarpal joint arthrodesis is favored for the young patients who might have post-traumatic arthritis after. For example, after the treated Bennett's or Rolando fracture. So for an older patient with primary osteoarthritis at the thumb base, excision of the trapezium followed by the tendon suspension, that is interposition arthroplasty, may be preferred. So older patient, primary osteoarthritis, we have to excise the trapezium followed by tendon suspension procedure. Arthroplasty should be done. So deformity in rheumatoid arthritis. Till now, whatever I told is in the osteoarthritis. In rheumatoid arthritis, what are the deformity? Swan neck deformity. Another one is Botinier deformity. Yesterday itself we saw. flexion at the PAP joint with concurrent hyperextension at the DAP joint, that is Botinier. Opposite of Botinier is swan neck deformity. Okay. Then joint subluxation, radial deviation. This has been asked, and ulnar deviation and flexion of the fingers. So wrist will go for radial deviation. Okay. So ulnar deviation, fingers will go for ulnar deviation. This is important point in this rheumatoid arthritis. That's it. Next, coming to the contracture. Contracture, Walkman's ischemic contracture. This most common contracture results from the untreated compartment syndrome of the forearm and hand. So FDP and FBL muscles are usually affected. So this is what I told already while reading there. I told the deeper muscles are involved, FDP and FPL. Okay. So Bunnell's test I already discussed. Intrinsic contracture can occur in the hand, okay, in which the passive extension of the metacarpophalangeal joint makes passive flexion of the PAP joint more difficult. Okay. So milder form you can treat with splinting and stretching. Severe form Z+T can be used. The flexor pronator muscle slide can be used. Most severe form of this Walkman ischemic contracture is treated with tendon transfers. So post-traumatic contractures are the most common type of the contractures. So if they are mild, they are able to stretch out by exercise and hand therapy. If these contractions are severe and functional deforming, then surgical release of the joint contractures and release of the tendon adhesions may be required. So next, coming to the Dupuytren contraction. So Dupuytren contraction is one second. Hello, am I audible?
Audible.
Okay, call came in WhatsApp. So Dupuytren contracture, it is the contracting collagen affecting the palmar fascia. So it can also affect the dorsum of the fingers, that is knuckle pads, soles of the feet, and penis. In penis, it's called Peyronie's disease. Okay, it is thought to be a hereditary Mendelian dominant, autosomal dominant disorder. Okay, it is bilateral in 65% of the cases. It is 6 times more frequently involved in the males. And carpal tunnel syndrome is involvement in the females, whereas Dupuytren contracture is more common in the males. These two things will confuse. Okay, remember. So 6 times more common in the males and predominantly involves the ring and the little finger. So the process of Dupuytren contraction occurs in the normal bands of collagen that form the palmar fascia, natatory ligaments, and the digital sheets. So nodules containing the myofibroblast and immature collagen develop in these tissue. So mature is replaced by the immature. So treatment is surgical excision. It is indicated in the MP joint, MP metacarpophalangeal contracture of 30° or more. So this is important MCQ. Okay. What is the indication of surgery? Metacarpophalangeal joint contracture more than 30°, with which when the patient fails the so-called tabletop test. Okay. So tabletop test means the patient cannot place the palm of the hand flat on a surface. It's okay, easy test only. So whenever there is a PAP joint contracture, so careful surgical technique is necessary. Collagenase injections can be used. So this collagenase enzyme is derived from which bacteria that they have asked? Okay, Clostridium histolyticum. Okay, Clostridium histolyticum collagenase enzyme. Then percutaneous needle fasciotomy is also a reasonable option for treatment of Dupuytren's contraction and seems to be effective for the MP joint contraction, but less effective for the PAP joint contraction. So these are the various treatment modalities for Dupuytren's. Most important points are involvement of palmar fascia, bilateral and 65, 6 times more common in male. Okay, mature replaced by immature, more than 30° MP joint treatment is indicated. Okay, then tabletop test is positive. Then other treatment options I have told. Then future directions in hand surgery. In this one MCQ is there. First, sorry, this is not an MCQ. So this here. So the gold standard has been to use a autologous nerve graft, but this tissue, but this option has a donor morbidity and there is limited nerve supply available. So treated cadaveric nerve allografts remove the immunogenicity and may enable the nerve reconstruction without donor morbidity. So for this nerve lesions and all, the best thing for a large nerve defects will be autologous nerve graft. That is what is performed till now. Okay, but since it has donor site morbidity, a new treatment option has come out. That is your cadaveric, treated cadaveric nerve allografts. So in options you see, if the treated cadaveric nerve allografts is there, that is used because it removes the risk of immunogenicity, okay, and may enable the nerve reconstruction without donor site morbidity. So to date, this has been used successfully for short nerve gaps in major upper limb extremities nerves. The nerve allografts contains the full scaffold of the nerve, which allows for the greater guidance of axonal growth. Autologous autografted nerves also contains the Schwann cells and growth factors that in theory should help the increase the axon growth and take develop. So at this time, it is uncertain what the length of major peripheral nerve is best treated with the autograft versus an allograft. So here in point to notice, autologous autograft nerves will contain the Schwann cells and growth factors. So in the next diagram, you can see a page. Okay, there's a diagram here. That is nerve conduit with no internal structure, whereas allograft will have an internal microstructure. That means this Schwann cells and all these things. Next, there is a big tabular column. Okay. In spite of having so much, if the examiner is lazy, or if he wants to ask easily, then he will straight away turn to this page and take a question from this tabular column. Most of the things we have already discussed in the theory inside. Few things I will just brush it up. Okay, so fracture of the distal radius, which nerve is involved? That is the median nerve will be involved. So innervation of the flexor digitorum profundus to the ring and the small finger is by the ulnar nerve. So distal falling fracture is the most common of all hand fracture, more than 50%. The joint involved in the Bennett's fracture is carpometacarpal joint of the thumb. So most frequently fractured carpal bone is scaphoid bone fracture. Okay, then the avascular necrosis of scaphoid is called as Preser's disease. That I have written. They didn't give here. I have just mentioned Preser's disease. Whereas various avian names are there. For scaphoid, it is Preser's. So common maximum tourniquet time in hand surgery is 2 hours. Then this thing is important. How will you transport a nerve? Okay, transport an amputated digit. This has been asked already. So first is cleaning of debris. Then it is wrapped in a small towel or gauze. Then it is moistened with the sterile lactated ringer solution. Then it is placed in a sterile plastic bag. Then it is placed in a ice or ice water of temperature 4 degrees Celsius. Okay, this is important. Okay, then so maximal period of anoxia compatible with replantation, it is 8 hours is the warm ischemic time. For upper and lower extremity, it is the 6 hours. So if the nerve repair is delayed for more than 2 weeks, then there will be retraction of the nerve ends. Then mallet's finger, I have already told. Gamekeeper's thumb, you note it down. Okay, that is I already told. Rupture of the ulnar collateral ligament. Okay, of the thumb metacarpophalangeal joint with resultant instability of the force to the radial directed force. Joint involved will be thumb metacarpophalangeal joint, but ligament ruptured will be ulnar collateral ligament. Then most common location of the ganglion cyst, I already told. Scapholunate intraosseous ligament at the dorsal wrist. So treatment of decurvent stenosynovitis, surgical release of the first extensor compartment. Then cause of trigger finger is stenosynovitis in the metacarpophalangeal joint at the A1 pulley. Then swan neck bottinier, you know already. So non-operative measures of Duptrain. Here you note it down. Non-operative management. They told this collagenase injection, steroid injection, needle, all these things. Radiotherapy they didn't mention in the theory. They have given here. So radiotherapy is also a treatment option. Then fractures likely to cause the compartment syndrome, Volkmann's ischemic contracture is supracondylar fracture of the humerus. This is important point. So which nerve is affected in the Volkmann's ischemic contracture? This is very important point. One is median nerve, but artery is anterior interosseous artery. Anterior interosseous artery is a branch of the it's a branch of the ulnar artery. Anterior interosseous nerve is branch of median nerve, but anterior interosseous artery is a branch of ulnar artery. Okay, so that's it. So in this class, I will recommend you to go through and see three things. One is this tabular column. Okay. Another thing is the congenital hand anomalies, polydactyly, syndactyly, and all those things. Then you have to go through the syndromes, that is carpal tunnel syndrome, pronator syndrome, this ulnar nerve compression syndrome, radial nerve compression syndrome. Then you read about bit about the Dupuytren's contracture. These are very common topics. Can expect question. Okay. Thank you.
Thank you, sir.
Okay, thank you, Yogesh.